So auditory hallucinations, again, are probably the most common type of hallucinations that we see in people that have schizophrenia and also in people that have a psychotic depression or bipolar disorder. So there are ways that people can learn to cope with them. Hopefully the medication will at least make them not at a 10 on a scale of 1 to 10, but they will be either decreased or hopefully diminished completely to the point where the person doesn't hear voices anymore. But again, that doesn't always happen. So for the person that medication doesn't seem to work and they always have some level of hearing something, auditory hallucination, voices, noises, whatever, there are ways that people can learn to cope with these. So, but the thing to remember is that think about CUSIN, patient-centered care. So what works for one person might not work for another. So if somebody is having a hard time with their hallucinations or rating them at a 9 out of 10 and they don't want to come out of their room, they don't want to go to group, they don't want to go out for breakfast or anything like that, we have to use our concept of patient-centered care and make sure that we honor that, because it's possible that for that particular person, coming out of their room, going to the dining room, talking to other people, being around other people would stimulate them to have further worsened hallucinations. And so we don't want to put somebody in that situation where that increased level of stimulation is going to make them worse. So for some people, being out and talking to other people helps them, and for other people, being by themselves is more helpful in their own room, quiet. So it's, again, use that patient-centered care principle, find out what works for that individual person. So even with listening to music or TV, sometimes it makes it better for some people, but for another person, it's going to make the hallucinations worse. So we really have to kind of figure out what works for that person. And of course, asking them is very helpful. What helps you when your hallucinations are at a 9? So for some people, listening to music or TV, dismissing the voices, which is kind of the same thing as tell the voices to go away, which is kind of the second from the bottom. So just saying, nope, I'm not going to listen to them, or verbally saying, voices, go away, stop talking to me. It gives the person, it may seem kind of silly, but it actually gives the person a little bit of a feeling of having some control over the voices, that not that they're just a victim. Using headsets, even pretending like to talk on a phone or something like that helps. Talking with others, again, may or may not be helpful. Hum, sing, whistle, read out loud, go for a walk, or another enjoyable activity. All those things are possibilities that might work for different people. So these are some drawings that I found online, and actually I just put a link, I think it's the link in Blackboard under Learning Plan 5. I believe it's right above the discussion question, under Learning Plan 5. So it'll say, I think it says 18-year-old artist, something about with schizophrenia, I don't know, or with hallucinations. But anyways, read that article. You should just click on it and just scroll through. The girl is absolutely beautiful, and she talks in the very beginning, there's just little bits to read here and there. It's not like reading a huge full article. But she talks about how the stigma of the illness, and she even hates to tell people she has schizophrenia because then they look at her as just the illness. And of course, she talks a little bit about how Hollywood doesn't always help with that, and just the stigma attached. And this is how she is coping with her auditory and visual hallucinations, is by drawing pictures. So if you scroll through, you're going to see this slide and the next slide shows 2 of her pictures, but there's a few more in that article. So do click on that link and at least scroll through and look at her pictures. But anyway, she started drawing her hallucinations as a way to cope with them. So on the left is like disembodied eyes. So that is something that she sees sometimes. And the one on the right, I think she said that she sees this sometimes, like crawling around on the floor and makes a clicking noise. So it's kind of a combination of auditory and visual. And then this one too is something else that she sees sometimes, like a person with no eyes. So her name is Kate, and definitely just click on that link and just kind of scroll through a little bit. So just gives you a little bit of an insight into some other different ways that people use to cope with their mental illness. So alterations in behavior is something else that we sometimes see in people with schizophrenia. And all of these, of course, don't have to exist in that same person, but just, we may or may not see some of these symptoms in different people. Not everyone is catatonic. So we'll start with catatonia. And actually, you can also have catatonic symptoms along with depression. So, and also actually bipolar too. So, you can see that symptom in other illnesses also. So in Vaccarolus on page 199, they're describing catatonia as it's a pronounced increase or decrease in the rate and amount of movement. Usually what we see is that people have a decrease in the amount of movement to the point of being actually just completely inert. They don't move, they don't blink their eyes, they don't sometimes open their eyes, they keep their eyes closed, they don't move. And the other type of catatonic behavior would be if the person has a lot of just random purposeless movement. So they're not really accomplishing anything. And that goes along with echopraxia and echolalia. So we haven't gotten to echopraxia yet. That's on this slide. So that's just basically like copying somebody's bodily movements. And echolalia, I think we talked about that already, is when you somebody just repeats something. You say, "How are you today?" and they say, "How are you today?" They don't answer your question. So they might do some of that, echopraxia and echolalia, and just randomly moving around, purposeless. We don't often, I don't know if I've ever really seen that type of catatonic behavior. Usually I've seen people that are just completely inert. So think about the nursing implications for caring with somebody who is catatonic. They're not eating, they're not drinking, they may not be taking their medications, they're not going to the bathroom, they're not doing anything on their own. So it's almost like when they're in that type of situation, they are like the ICU of mental health nursing. So they need intensive care from the nurse. We really have to try very hard. It's difficult because sometimes you don't want to pry somebody's mouth and, lips and tongue and teeth apart, not tongue, lips and teeth apart to get them to eat, but at least holding things up to their mouth and seeing if they'll open their mouth. But if we never offer, then we're not even giving them the opportunity to eat because they can't do it on their own. They truly can't. So they're very seriously medically and psychiatrically ill if they are in this type of a condition. So we have to at least try to get them to hold things up to their mouth, see if they can take their medication orally, see if they can take at least sips of fluid or maybe some soft foods. Like I would start with like puddings, ice cream, things that they're not going to choke on. We have to make sure that they get to the bathroom. So either if we can put them on a bedpan, if we can transfer them to a commode. It's sometimes difficult to actually walk them to the bathroom because they might be, even though they're not really moving or responding to you, they might actually actively resist you trying to help them. So it might be difficult to get them up and walk them to the bathroom. But just think about all of the muscle complications and pressure ulcers, dehydration. There's a lot of medical complications that are going to occur if we just let that person sit there. So it really takes a lot of nursing intervention when that person is so very acutely ill. As far as giving medications against their will, we kind of talked about that in Learning Plan 1. It's a patient's right to refuse medication. It would have to come to a crisis situation where the person's health was so impaired, and my guess is the doctor would probably seek an order from the court to be able to give them medications or food and fluids against their will, because technically they do have the right to refuse. They can refuse fluids, they can refuse foods, they can refuse their medications as long as they're not a danger to themselves or others. But truly, if they're refusing food and fluids and nursing care, they are becoming a danger to themselves or others. So that's at the point where the court might need to get involved. So they really are very challenging to take care of. The one thing to remember about when somebody is catatonic, I actually had a student some years ago have a great opportunity and experience to work with somebody who was catatonic, and it came to the point of we could not get her up to go to the bathroom. She wouldn't go on a bedpan. So we were getting to the point of we had to straight cath her in order to, relieve her bladder. So we ended up doing that, and the student did such a great job of talking to the patient through the whole thing. Now, it would have been just easy just to go ahead and do the procedure without saying a word, because the patient had her eyes closed and was not responding at all to what we were doing. She wasn't resisting, which was great. So my fear was that she was going to lock her knees together and we wouldn't be able to, to be able to cath her, but we did. And but the student talked to her the entire time, told her what she was doing. Okay, you're going to feel me clean you off now. Now I'm going to be inserting the tube to drain your bladder. I mean, just did a really beautiful job. And then the student, after the procedure was over, we had a couple of students in there, and I left. I had to go do something else, and the students stayed in there. And even though the patient was not responding at all, eyes closed, it's like she could have been asleep, but she wasn't. The students continued to talk, and they were trying to talk to her, even though she wasn't answering back. And I guess it was around Halloween time. So they were talking about pumpkins and Halloween coming and various things. So the next week, when we came back, the patient was better. She had been starting to take medication and was improving. And she remembered the students being in there doing the straight cath, and she remembered them talking about pumpkins. So if we think that people that are catatonic aren't paying attention to us, they're not listening, we can say whatever we want or do whatever we want, that is absolutely not true, because she was paying attention. She was aware of what was going on and remembered a conversation, which I think is pretty incredible. But so just in terms of, it's so hard to interact when somebody isn't even looking at you, when they're in that state. But that's such an important point, that they really are there, but they're so ill that they can't respond to you. So anyways, I had to tell you that little bit of a story about a person who was in a catatonic state. Motor retardation. So that just basically means a slowing of movement. So they move slower, they shower slower, if they shower at all, they eat slowly. Everything kind of happens in a very slow manner. At motor agitation, of course, then is just the opposite. So they might be running around, they might be pacing continuously, rapidly, and it might be in response to internal or external stimuli. Internal stimuli is things that are like hallucinations, like voices, visual, auditory, things like that. Or external stimuli, they might be pacing in response to excessive stimulation on the unit, like from other patients, especially if other patients are kind of loud and making a lot of noise, they might respond to that. Stereotyped behaviors. So that's repetitive behaviors that don't really serve a logical purpose. So it might be, somebody might be going along the hallway, up and down the hallway, and just constantly like touching or tapping the side rails or doorknobs or something like that. Just, it doesn't really have, it's a repetitive behavior, but it's not really serving a purpose. Let's see, waxy flexibility. So waxy flexibility kind of goes along with gesturing or posturing on the opposite side of the slide. If somebody is in a catatonic state, many times they exhibit what we call posturing, and that is like striking a pose. It's kind of like they're playing that kids game of statue or whatever, where you kind of strike a pose and you stay that way for hours. That's basically what another symptom that people can have when they're catatonic. So they stay in that same position for long periods of time. If you come along and you take their arm and you move their arm, like maybe their arm is up over their head and you move it down, then they're going to keep their arm down. You come back an hour later, you move their arm back up again, and then they keep it that way. So I believe I also have a little bit of a YouTube video showing waxy flexibility. If I remember correctly, it's a really old video, but it is an accurate representation of what that looks like. So we just kind of covered then gesturing or posturing. Gesturing actually is just kind of not quite the same as posturing. I guess a good example would be a few years ago when we actually had a mall in Sheboygan. There was a guy who I'm pretty sure probably had schizophrenia, but I would see him in the mall quite a bit, and he'd be walking around, and he would be using his hand to look like a gun, and he would make noises that would sound like a kind of like popping noises, like a gun going off. So that to me would be an example of somebody who is gesturing. So in posturing, we talked about striking a pose, and then waxy flexibility, the pose. You can change the pose and they will move their arm up and down, and they will leave it wherever you put it. Talked about echopraxia already, as far as like imitating, aping other people's bodily movements. So again, kind of purposeless. Negativism is actually, again, what I was worried about with that person in a catatonic state who we were doing a straight cath. I really thought that she would like just lock her knees together and we would not be able to straight cath her. So that would be an example of negativism, where people just actively resist what you're doing, or you're trying to give them medications or have them take a sip of fluids and they clench their teeth and they tighten up their lips, and you just can't get them to take anything orally. So that would be another example that I see quite often of negativism. Impaired impulse control is another type of behavioral problem that we sometimes see, and they just do things impulsively. You probably understand the concept of being impulsive, like there's not much time between thought and action. They just kind of do something very abruptly, and that can be the type of behavior that can spur on violence, especially from other people. So if a patient is throwing food in the dining room or something, maybe some other patients might get mad, and that could lead to an altercation. Something else that I've seen in the clinical setting along with impulse control is sometimes when patients refuse medication, they'll look like they're starting to take it, and then they'll kind of bring it up to their mouth, and all of a sudden they'll like take the med cup and just throw it on the floor. They'll take the water and just throw it on the floor or throw it at the nurse. So those types of impulsive behaviors also can exist. Talked about gesturing and posturing already. Boundary impairment is interesting. In a person with schizophrenia, there are many times when it's almost like they don't know where they end and the other person begins. So they tend to invade our personal space. They come really close to us. They don't even realize how close they're coming. They just don't have a sense of personal boundaries and boundaries of the other person. So I've noticed this sometimes just standing in the hallway on 1K during clinical, and sometimes a patient with schizophrenia might be pacing, and they'll come within like a fourth of an inch of me and not even flinch, not even like realize that they're coming that close. As part of the boundary impairment, sometimes patients might even eat or drink somebody else's food off of their tray because they just think it's theirs. They don't really have an idea that they have their own food on their own tray. So they may in the dining room reach over and grab something off of somebody else's tray. So again, some of these behaviors can lead to altercations with other patients. So negative symptoms. So we talked about positive symptoms, which remember are not good, not positive in a good way. Now the negative symptoms, I kind of call those the blah symptoms, because these are essentially, it's the absence of essential human qualities. So anhedonia, avolition, asociality, affective blunting, apathy, and alogia, or poverty of speech. So these are things that just make us vital, healthy human beings, and people with negative symptoms don't have these. And sometimes these symptoms can really look very depressive. So that's a reason why we really have to pay attention to these negative symptoms. So anhedonia means the absence of pleasure. So they can't experience pleasure. Things that maybe they used to enjoy at one point in their life, they they're not fun anymore. They don't enjoy them. So again, that is a symptom of depression. I believe we probably talked about that a little bit when we were talking about major depressive disorder. So anhedonia, just nothing is fun, nothing is exciting, no pleasure in anything. So just think how awful that would be to have that. Avolition. So the absence of, to me, volition is like get up and go. It's that thing that drives you to get out of bed in the morning, accomplish goals, get things done. If they don't have that avolition, it is really hard for people to get out of bed, to shower, get dressed, go to breakfast, go to group, have a productive day on the unit. We're going to see those symptoms quite a bit. Especially in terms of doing ADLs. It is so difficult sometimes to get people with schizophrenia to get in the shower can be a huge, major accomplishment. But if they don't have that internal volition to get up and shower, that's where we come in with our nursing interventions to really encourage and try to help to get that person in the shower. We are not going to drag somebody into the shower kicking and screaming. We're not going to do that. We're not going to force them to do that. However, a lot of encouragement can be very helpful. And one of the most helpful things is just to kind of be very structured about it and almost not give them a choice. Now, in a good way, it doesn't have to be negative. You can say, here's your stuff to take your shower. Here's your soap, your shampoo, and your towels. I'll walk you over to the shower room and unlock it for you. And that's just kind of giving some structure. It's like you expect them to follow through. And sometimes they will follow through because you're providing them with structure. A good example is a patient had not showered, let's see, this was March where he was admitted a few years ago. It was in March. And he had not showered or washed his hair since Thanksgiving. So that was 4 months, right? About 4 months where he didn't shower or wash his hair or, trim his beard, have his hair cut or anything like that. So his ADLs were really, really lacking. The student was assigned to him, and the student just kept at him and just kept, here's your stuff. Let's, I'll help you. Let's go take a shower. No, and kind of kept refusing. And I think sometimes giving a choice too can help. Do you want to take your shower at 9 o'clock or 10 o'clock? But it's, again, still, if you say it with the anticipation that they're going to follow through with it, sometimes that's enough. So this one student just kept at this patient, kept at him, and just, come on, let's take a shower. And here, I'll open up the door for you. Here's your stuff. Finally, the patient followed through and went into the shower and took a shower. And then when they were done, they said, oh, I'm so glad that you really pestered me about this because I feel so much better now. So it is important that we pester people a little bit in a nice way, of course. Again, we're not going to drag anybody in there against their will, but I think that if we really offer some support and encouragement, that's such a helpful nursing intervention. Another patient I remember was about 6'5", just a really large, tall guy. And the student assigned to him was a tiny, very, very short female. And again, she could have been just really afraid of this guy and really, kind of hesitant to get in there and intervene with him. But he also hadn't showered in quite a while. And so she gathered up the supplies and she said, he was paranoid and he was just afraid to go in the shower. So she finally said, you know what, I'm going to stand, here's the stuff to take your shower. I'm going to stand right outside the door and I will make sure that you're safe. And with that intervention, the patient was able to go in and take a shower. So sometimes we just really have to work around patients' insecurities, find out what it is about the shower that bothers them. This person was just afraid to be in the shower room. And certainly if they want, we can go in there with them, but we just have to make sure that we don't go in against their will because we don't want to invade their privacy if there's not a good reason to do that. So that's probably enough about avolition. I guess I just see it mostly in ADLs. So that's where I see it on the mental health unit. But it could really be any just lack of get up and go for any type of goal-directed behavior. Asociality is they just don't have a desire for social interaction. They don't get a lot of comfort out of talking to other people. It is really difficult for them to relate to other people, to talk to other people, to carry on a conversation. So that's really tough for them. And going to groups sometimes can be very difficult. Again, everybody is different. Everyone with schizophrenia is a unique human being. There are some people with schizophrenia that enjoy contact with other people more than others. And there are some that just really have a hard time and almost want no contact with anyone, even have a hard time with short, frequent contacts with their nurse. Affective blunting, so reduced affect or a constricted affect, so they don't have a wide range of facial expressions. They maybe have just, a little bit of expression, but not as much as another person would. So apathy is just that decreased interest in or attention to activities or beliefs that would otherwise be interesting or important to them. So they just don't care. They don't really have, they don't care one way or the other. So if you say, hey, we're doing something really fun in group today, who cares? They just have that lack of interest. Alogia is poverty of speech. Now, this is kind of frustrating for students. I've got a little cartoon on the next page here. It's kind of the inability to speak because in this case, because of the diagnosis of having schizophrenia. So this person is saying, where do you live? And the other person, the female who has the illness, isn't really responding. So this alogia can be very frustrating for students because you want to go in and sit down and have a one-to-one and talk to them and maybe do your process recording on this person, and you're not getting anywhere. And you are going to feel like a failure, but don't feel like a failure. It's not you. I can't tell you how many times in the 23 years I've been teaching at LTC that I've had to reassure students, don't worry, it's not you. It's not that you're not saying the right words, you're not saying the right magic phrase to get them to talk. It's their condition, it's their illness. So they can't just sit down and have a great conversation with you. They can't, part of alogia is they really have a hard time coming up with a topic of conversation. And sometimes then they also can't respond very easily to what you're asking them. So it's going to feel to you like you're pulling teeth to get them to talk. So the typical person with alogia, you're going to say, so where are you from? And they're going to say Sheboygan. And you're going to say, whereabouts in Sheboygan? In the town, in the city, on the north side, the south side? And they're going to say on the north side. And then you're going to say, well, do you live in a house? Do you live in an apartment? And they'll say apartment. And then you're going to say, do you live with anyone? Do you live by yourself? And then they're going to say they live with their sister. So it's like they can't just spit it all out and have a normal flow of conversation. It's just kind of like literally pulling teeth to get them to say anything, and sometimes they just can't even come up with a topic of conversation on their own. So that is a really frustrating thing, especially for students. Okay, so affect. So let's just break that down a little bit more because that is part of the negative symptoms. So that's, again, I think I mentioned that in the mood disorders learning plan 3. So affect is the outward expression of a person's internal emotional state. So affect, when we're thinking about a person with schizophrenia, having a flat affect just means absolutely no expression whatsoever. So you look at their face, you cannot read them at all. You don't know if they're sad, angry, happy. You have no idea because they have no emotional expression at all. On some occasions, this having a flat affect could possibly be a side effect of medication, especially if they're on the older classification of the first generation of antipsychotics. There is something called a masked face, and it's kind of like they're wearing a mask. They just don't have any expression. So it's possible it's a side effect of medication if they've been on those classes of, that class of medication. but it is also an actual symptom that we might see. Again, blunted is reduced, so they might smile, but it's not going to be a big smile. It'll probably be just a little smile, or if they look mad or sad, it's just going to be a little bit of an expression, but not like the full expression of that you would see in somebody else's face. Having an inappropriate affect means that they might be responding to something in a way that's the exact opposite of what you would expect. So they just hear that somebody died and they start laughing. So it's kind of the opposite of of what you would expect. Or you tell them something really that should make them really happy and they start crying. So it's not appropriate to the situation at all. And bizarre is really kind of just what it says. It can be odd, illogical, inappropriate, or just like unfounded, and includes sometimes people have different types of facial grimacing. Again, facial grimacing could possibly be a side effect of medication, but it can also be one of the negative symptoms if they just have a really odd, unusual look on their face or some kind of grimacing. So cognitive symptoms, again, that concrete thinking. So very hard for them to think in an abstract manner. So again, nursing interventions, we really need to make sure that we choose our words carefully and try not to say things that the patient could easily misinterpret, such as, again, don't say you're taking their blood pressure because they may think you're taking it out of their body. So just for us to kind of watch our words and think carefully about what we're saying. People think concretely, they also have a great deal of difficulty kind of responding to concepts requiring abstract reasoning, such as love or humor. So, nursing intervention, think about not joking around with patients, because we might think we're trying to lighten up the situation. They're so serious and we're trying to joke about something, but you know what? They're not going to take it the way that we are meaning it. They, again, are taking things very concretely and very literally, and they may miss the idea of the joke, or they may even think that you're making fun of them somehow. So we really have to watch, again, very carefully and make sure our communication is just very clear, very simple, and very direct, and really try not to insert even any, it sounds terrible maybe that we can't even use any humor, but truly, if you get used to working with people with schizophrenia, you're going to understand why that would be such a negative thing. They truly don't understand the humor the way that we do. Okay, impaired memory. So sometimes their short-term memory is impacted and the ability to learn. So we might have to do some repetition and some verbal or visual cueing, and that can be really helpful, especially if we're doing patient education. And the example in your book on page 200, they talk about putting a picture of a toothbrush on the patient's wall as a reminder to brush their teeth. So they do, respond sometimes to cues. Impaired information processing. Again, the patient might have delayed responses, and the other problem that can happen is that they lose the ability to screen out insignificant stimuli. So it's like their brain gets overloaded very, very easily. They can't filter out what's not important to pay attention to, and so they can really become very, very easily overwhelmed and overstimulated. Impaired executive functioning. So that's executive functioning is what keeps you going as nursing students. So that ability to set priorities, reason, compare your options, put things in a logical sequence, anticipation, planning. So it's all of those higher level cognitive functioning that keeps you going. So if they lack that, then they really have a hard time with any type of problem solving, and it can contribute to inappropriateness in social situations. Also, think about how hard it would be then for the person that has schizophrenia, if they have difficulties with that executive functioning, how hard it is for them to get to their appointments on time. And if there's anything that happens that's out of the ordinary, that's going to completely throw them off. So, perhaps they go to microwave something. They're going to eat breakfast in the morning quick before they get to their appointment, and their microwave doesn't work. So that's going to just throw them off, and they can't problem solve and plan something else. So that's going to throw them off. They may not ever make it to their appointment. Just that ability to plan and to organize things. So it has an impact on their behavior as far as following through with appointments, and also following through with taking medications, taking care of their health. Again, think about the person with schizophrenia that also has a chronic health condition, such as they're trying to manage diabetes along with their schizophrenia. Wow, extremely difficult, way more challenging for that person rather than anybody else that might have diabetes. So that impaired executive functioning really has a great impact on their overall health. Affective symptoms. So assessment for depression is absolutely crucial, because that might be the sign that they're having a relapse, and that increases their substance abuse. Because think about it, even if a person who doesn't have schizophrenia gets depressed, there are people that turn to substances, alcohol and other illicit drugs, to try to feel better. They think it's going to make them feel better. So this person with schizophrenia absolutely is going to be turning to substances. And that is going to increase their risk of suicide, and it further impairs their functioning. So if they're already having a hard time with their volition and their get up and go and their ability to do things, even just getting into the shower, brushing their teeth, it's going to further impair functioning if they're having depression. So again, remember, depression and anxiety certainly are big comorbidities with schizophrenia. So again, we really have to think about the depression and that risk for suicide. And also, if somebody is having more affective symptoms, more depression, we really need to figure out if they're having command hallucinations to kill themselves, because that is a very serious symptom, and people do follow through with killing themselves when they're having hallucinations telling them to kill themselves. So very careful assessment by the nurse. Self-assessment. So the anosognosia, which is kind of a big word, basically means that the patient has that inability to realize that they're ill. They truly are in denial. They don't know that they have schizophrenia. They don't understand that however they're feeling is an illness, and whatever symptoms they're experiencing is an illness. They truly don't get that. So therefore, it is very difficult to get them to take medication. I can think of a young patient who is just probably fairly recently diagnosed with schizophrenia. Again, young male, late teens, early 20s. I believe he was in his early 20s, and really had an extremely difficult time, probably is still having a difficult time with that diagnosis. We try to do teaching. Again, in the old days, I think I mentioned this before, we never told a patient what was wrong with them. We never told them about their illness. And now we're really doing a lot of teaching. But if you're having that inability to realize you're ill, then which basically is what anosognosia means, that it's really hard for them to accept treatment. They don't want to go to therapy. They don't want to take their medications. So usually when they're discharged from the hospital, we might have everything set up and everything looks great. Patient goes home, they stop taking their medications, and they start self-medicating with drugs and alcohol, come back into the hospital. So that's kind of a cycle we see sometimes. I think with this young gentleman I'm thinking of, I believe that they were court ordering him at least for a 6-month period that he had to take his medications and follow up with therapy. But, after that, who knows what's going to happen? It's so difficult when they don't understand what they have is an illness. And not everyone has that. There are people with schizophrenia that can tell you very clearly about their symptoms. They can tell you about their illness, describe what it's like, and other people are more social again, and some people are less wanting to be around other people. There's so much variation. It is just really, truly a very individual disease. But anyways, that is that anosognosia is caused by the illness itself. It's kind of like another symptom that they might have. So again, they're going to be resistant to treatment or stop treatment altogether. And it might be combined with paranoia, so that accepting help is almost impossible because they are really suspicious of your motivation. Why do you want them to take medication? What they might think you have something is in it for you, and you have an ulterior motive. For the self-assessment, the nurse really needs to deal with his or her own feelings about working with somebody with schizophrenia. It can be very challenging. You really almost never really know if you've got a good, trusting relationship with somebody with this illness or not. They just don't respond the way other people do. And, as nurses, we want people to respond, right? We're in this field because we want to help people. We want to see them feel better, and we would love it if they would be able to acknowledge and say, oh, you were so helpful. And, we all are, it's wonderful. We're all kind of looking for that positive feedback of seeing somebody do well. We might not ever get that when we're working with somebody with this illness. I'm not saying it's impossible that we can develop a relationship with somebody with schizophrenia. Because it is absolutely possible, and it is something we have to work hard at to get their trust. That is so important to maintain to get them to trust us, especially if they're paranoid. And it is not impossible. It just takes a lot of concerted effort and insight on your part, and making sure you, again, choose your words carefully, do what you say what you mean, treat the person with dignity and respect, and usually over time, that relationship can develop and that they can at least trust you and they're able to work with you. Another little quick story. This one patient that I don't know him really all that well. I probably had worked with him, maybe 10 years ago or so. More than that, when I was working as a casual staff member. So he doesn't really know me that well, but I know that I have worked with him in the past, and he was on the unit a few years ago, and he apparently didn't remember me at all. And he was out, they let him wear sunglasses on the unit because of his paranoia. So, because that makes him feel better. If he has sunglasses, it's kind of a barrier. So he had his sunglasses on, and he was coming up toward the nurse station because he was eating in his room, and he was done with his tray, and he was kind of looking like he didn't know what to do with his tray. So I was standing in the hallway, and I started slowly approaching him and said, oh, I can take that from you. You can give the tray to me if you want. And he just kind of looked at me, like kind of glared and was like, no, he said, I want a regular staff member to do that. I was like, okay, so I backed off, and, clearly he didn't recognize me from having worked with him years before. And he recognized me enough, though, to think that, I don't really know this person. So no, I'm not even going to give you my empty tray that I've just finished my food. I'm not even going to give you my tray. I don't really trust you. So trust has to be developed over time. It is not impossible, but we do have, as nurses, we do have a lot of sometimes expectations for ourselves and for the patient that are not going to be met, so we can be frustrated. We can also have some anxiety and fear in working with a person with schizophrenia because, again, the stereotype is that everybody with this illness is violent, and yes, some people do have a history of violence, but not everyone is going to act out violently. And I do think that there are ways that we can help to avoid situations really by assessing the patient carefully, reading their cues. We can kind of figure out what sets people off and what helps them to calm down and to avoid being overstimulated so they don't get into a situation where they're going to be, become violent on the unit. So, again, we always have to look at our own feelings and make sure we're interacting in a therapeutic way. So back to the case study. Eric becomes anxious and says, there are worms eating my skin, there are worms under my skin eating the hair follicles. How would you classify this assessment finding? Is it a positive symptom, a negative one, cognitive, or a depressive symptom? So I'm hoping that you're saying it's a positive symptom because, again, it's something like that's added on to like a normal human experience. Most of us don't have tactile hallucinations, or possibly this could be just a somatic delusion. I don't know if he's actually feeling the worms. If he is, it's a hallucination, tactile, but if not, it could be just like a somatic delusion. But that is always, hallucinations, delusions are positive symptoms. Assessment guidelines. We always want to look and make sure the person doesn't have any medical problems going on, either problems that are coexisting or as a result of their schizophrenia, or certainly as a result of their medications. We haven't talked about meds yet, but there's certainly a high risk of people developing metabolic syndrome and type 2 diabetes. So we absolutely want to always be assessing what other medical problems are co-occurring at the same time. And there are some medical problems that might even mimic psychosis. Some examples of some medical problems where you might have some psychotic symptoms would be DING toxicity, anticholinergic toxicity, some brain trauma, drug intoxication, delirium, fever, things like that. So we always want to make sure that we advocate for a full medical workup. We always want to assess for substance or alcohol use disorder because, again, huge comorbidity. And it certainly doesn't help their mental status at all. We're doing a complete mental status exam, so looking at their insight, their reality testing, judgment, cognitive abilities, memory, things like that, relationship support systems, coping resources, their strengths, their appearance, behavior, all of that. And we also want to include a cognitive assessment and to kind of make sure that when we see where they're at cognitively, then that will help us to perform things like patient teaching and look to see if they're having any memory deficits. On page 200 and 201, kind of at the bottom of 200 and then the top of 201, there's a very nice table in kind of orange that talks about some assessment guidelines. And so they're really going through questioning the patient, trying to assess for delusions and hallucinations. One thing that that is mentioned in the table that I haven't mentioned yet is that it's also kind of important how we talk to somebody about their hallucinations, because we don't want to imply that we think it's real. So instead of saying, what are the voices saying, it might be more helpful to say, what are you hearing right now? We don't want to imply that that we think the voices are real, or even if their delusions are real, because that could be kind of frightening for the patient too, if they think that we think that the voices are real or that their delusions are really happening. So it's kind of important for us to, again, to choose our words kind of carefully. We can't really argue with a patient, though, about their delusion. So if they say that they were flying around in outer space for 2 weeks in a space capsule, we can't say, oh, no, you weren't. Even though we know for sure that didn't happen, it's usually more helpful to say, I understand that's very real for you. However, I'm kind of wondering how that could really be. Just to maybe put a little bit of doubt in there, but we don't want to downright say, nope, that didn't happen. We don't want to argue with somebody about their delusions or their hallucinations. So again, assessing for hallucinations, delusions, assessing for suicide risk, personal safety, health, prescribed meds, if they're taking them or not, and if any of their symptoms are really impacting their functioning. And assessing family knowledge, of course, is very important. If the family has a good understanding of the illness, it's very possible that they could be helpful in keeping that patient compliant. And helping the patient to get their other health needs met, maybe in a more consistent way. If the family has absolutely no knowledge whatsoever, then they may be very interacting in a very difficult way for that patient, and maybe their expectations are really quite high for the person, and they may get very frustrated and not support that patient. And believe me, that patient really does need some support in the outside in order to be functioning appropriately. Okay, back to the case study. The psychiatric nurse conducting Eric's assessment believes he's also suffering from command hallucinations. Discuss what kinds of questions could help affirm this. So again, we would be asking the patient, what are you hearing? And you could say, I mean, honestly, I know I just said, I feel like I'm contradicting myself a little bit because I just said we don't really want to make it seem like we think the voices are real, but honestly, sometimes we have to ask, what are the voices telling you to do? If we say, what are you hearing? And they don't really admit to the fact that they're command, it's kind of hard to, I guess, put that in a different way. So it is important to find out if the voices are indeed telling them to do something specific, especially if they're telling them to hurt themselves or to hurt anyone else. So we really have to be very direct in our questioning when we're trying to figure this out, because QSIN, it's a huge safety issue. Okay, some potential nursing diagnosis for somebody with schizophrenia. So if they have positive symptoms, disturbed sensory perception, risk for self-directed or other directed violence, impaired verbal communication. If they're having negative symptoms, social isolation, chronic low self-esteem, they may really feel very badly about themselves because of their illness. They know that they're not functioning the same way other people do. They may or may not have insight into their illness, but they realize that they're not able to achieve the same goals and hopes and dreams that other people are, and that can make them feel really pretty badly about themselves. So, so when we're trying to identify goals, we always are thinking about, in that acute phase, patient safety, and try to get them stabilized on medication. And again, the difficult part is when they do have the right to refuse unless they're a danger to themselves or others. So sometimes getting them to take their medication can be very, very challenging. Phase 2 is stabilization. We want to help them to understand their illness and the treatments, and again, stabilize them on medication. So we as nurses need to be watching their response to medications, and of course for any side effects. We want to help them to control or cope with symptoms. So we can do a lot of teaching, whether it's group or individual teaching, about how to manage some of their issues that they face having this illness, and also some of their symptoms. The maintenance phase, really we want them to maintain that achievement to prevent relapse, and so that they have some independence in their lifestyle and a satisfactory quality of life, so they can at least feel good about their life in general and everything, everybody around them, and that they feel like they are contributing members of society. That's really what everybody wants in their life. Back to the case study. After an acute admission, discharge is being planned. What are some things that need to be considered? So again, who are Eric's support systems? It sounds like his family might possibly be good supports. We hope that they get some education so that they understand his illness. So family support and other support is very important. How about their finances? Do they have the money that they need? Do they have health insurance? Are they going to be able to afford their medications? Is substance abuse going to be an issue for them? Do they have any other comorbidities going on that need attention? Diabetes, asthma, any other kind of chronic medical condition? Are they going to be participating in any type of outpatient program? Are there programs even available to them in their community to help them with their functioning and to further adjust to their diagnosis and adjust to their illness? One thing we do have in Sheboygan County, it's called the Open Door, and it isn't necessarily just for people that have schizophrenia, but it's downtown Sheboygan, and it is just a place that people can drop in, and it's only open, I think, a couple days a week, but people with any mental illness can just drop in and feel accepted, and they can socialize if they want to. There's activities. I think they have a pool table or something, or ping pong, and games. Sometimes they have some structured activities for people. They have guests come in and teach people how to prepare different types of food using items that they might typically get from a food bank. So there are places that offer support, but it's really a matter of teaching the patient what is available to them and encouraging them to make use of the resources. So there really are a lot of things that we have to think about when somebody are going to be discharged. Again, their insight would also be something that we would need to assess. Do they have insight into their illness? Do they have the ability to truly understand the need for them to stay on medications, or are they going to stop taking their meds the minute they walk out the door? So those are all some things that we really have to consider. So planning. Again, the acute phase, the best strategies are to ensure the patient's safety and provide stabilization for those symptoms. And again, stabilization, maintenance, patient family education, very important, and relapse prevention skills are vital. So the implementation, again, I really do think that intervening with a patient is probably the most fun part of mental health nursing. So that in that acute phase, we really want to make sure that they get a good evaluation, medication, treatment, support, communication by the nurse is so very, very important. Again, I can't emphasize that enough about how difficult it is sometimes and challenging to form a relationship with somebody that has schizophrenia, but it is very, very rewarding and not impossible to do. Another little tip I have for you as far as communication, sometimes when the patient has the disordered thought process that I kind of talked about earlier, so they're having a flight of ideas and word salad or all those different things, again, try to look for a theme. Try to pick out sadness, fear, anxiety, whatever it is, try to pick out a theme and try to address their emotional state that's underlying, even if you can't really make sense of the words that they're saying. Supervision and limit setting in the milieu, because we want to make sure that they're safe and everybody else is safe. So if there is somebody that they're not getting along with, or their behavior is causing another patient to get angry at them, we have got to intervene in that milieu and make sure that everybody is safe. So sometimes the intervention might even be separating people. When we're in clinical on 1K, sometimes you'll see that they have certain hallways that are blocked off for all other patients, except only patients that have rooms on that wing can go down that wing. And it might be to keep certain people separated who are just really not interacting in a very good way, or perhaps in a very negative way, and we want to kind of keep them apart and make sure that violence doesn't actually erupt. So that supervision and limit setting in the milieu, if they're doing something bizarre or saying really bizarre things out in public area, to try to give them just some very nice constructive feedback. And again, just very, no, you can't say things like that. If you want to talk about that in your room, I'll go to your room, but you can't say that out in the hallway. Just limit setting is so very important on their behavior, and especially if they have some impulsive type of behaviors. We really want to set some limits on them. Monitor their fluid intake. Not everybody's going to be on INO, so basically it's your observation. If you notice that the patient is drinking excessive amounts, especially water, if they're asking for water continuously, you might want to put them on INO and make sure that they don't develop water intoxication. Working with aggression, we need to regularly assess for that risk and to take safety measures. So again, interventions, stabilization, medication administration, and adherence, trying to encourage the patient to take their medication on a regular basis. Again, that relationship with their trusted care providers, and make sure that we are trying to set up some community-based therapeutic services, teamwork and safety. We all communicate and work together no matter what the diagnosis. When somebody is admitted to a mental health unit, every single person needs to be aware of and ready to intervene in any situation they might see out in the milieu. So again, that's a CUSIN competency, that teamwork and safety aspect. Activities and groups, yeah, we love activities. We love to tell people everyone should go to group. But you know what? Some patients really just have a harder time in group than they would if they were by themselves. They may need some individual one-on-one work rather than going to a group if the group situation really makes them very upset and anxious. So counseling and communication techniques, again, hallucinations, we always want to find out what's going on, what the patient is experiencing. It is helpful sometimes to reassure the patient that you don't see what they see. They might be so frightened by their hallucination that they may, ask you, well, don't you see it? And it's okay to say, I understand that this is really upsetting to you, but no, I don't see what you're seeing. If you don't believe me, this really does work. So again, a little quick story. Patient was newly diagnosed with schizophrenia, and he was down in his room, and he was refusing anybody to kind of come near him. The student was on their way down the hall with medications, and the patient said, don't come near me. Somebody's going to get killed. So, of course, the student came back and told me that, the patient had said that. So I went with her and said the same thing. As soon as we got out in the hallway outside of the patient's room, he said the same thing. Don't come in here. You're going to get killed. I looked at the patient and I was able to assess that he looked frightened. And so I kind of approached him slowly. And he said, well, don't come in here. Can't you see? There's people outside my window with guns, and there's dead bodies all over the floor of my room. And so I said, I could tell, okay, he is hallucinating. He is really having a hard time right now. So I just said very calmly and very simply, I know that's really upsetting to you, but I don't see any dead bodies in your room. Here's your medication. And he took the medication pretty fast. So, people can trust us. I think they can tell if we're being open and honest with them. And it is really important to not to argue with them, but just to say, I get it that you're really upset by this. However, I'm not seeing what you're seeing. I'm not hearing what you're hearing. I think I've already mentioned about when people have loose associations, then we just are looking for that theme in what they're talking about. And health teaching and health promotion is always very important. People might not even understand like simple basic concepts. Like we had a patient who would come in that had schizophrenia. She would come in repeatedly, and almost every time she came in, she would have a urinary tract infection. And so we really had to kind of get at the root of, okay, what's going on here? And she really wasn't very good about her hygiene. And then she also admitted that when she was wiping herself, she was wiping from back to front. So she wasn't even wiping herself appropriately and was, kept getting repeated urinary tract infections. So sometimes we can't just assume that everyone knows basic hygiene. There are times that we have to make sure that we're teaching some of those basic things to patients. So now we're getting into medications. Okay, so we have antipsychotic medications. So some are oral and some are actually injectable. So some of the injectables are short-acting. So for an immediate situation, if somebody is in absolute crisis, they're going to hurt themselves or hurt somebody else, they are beside themselves, hysterical, anxious, psychotic, hallucinating, whatever, we might be able to give them a short-acting injection that's going to help them to calm down pretty quickly. There are long-acting injectable antipsychotics also that can help with people that are non-compliant. So in other words, instead of taking a medication by mouth every day or twice a day, whatever, and they may have a hard time remembering that because of those executive functions or lack of, and so we put them on a long-acting medication, and they just have to go to their doctor's appointment once a month or every 3 weeks or 6 weeks, whatever it is, to get that next injection. So it's a lot easier to get them there for the injections rather, so infrequently, rather than to be taking a medication by mouth every single day. So we're going to go over the antipsychotic medications. There's first, second, and third generation medications that we're going to be talking about. So those first generation antipsychotics, I call these the old antipsychotics. So I might just kind of say that every now and then. And this is all that was available when I first started my job as a mental health nurse in 1981. We really had nothing else available as far as antipsychotics. And these are dopamine antagonists, and they target only the positive symptoms of schizophrenia, not the negative symptoms. So some examples are Thorazine, Haldol, Navaine. You may or may not have given any of these medications. I believe there's probably still some patients that are on these, even though there are newer medications that are available, especially patients that are in nursing homes that maybe have been on these medications for years, and perhaps they're just very effective for them. And the prescriber just doesn't really want to mess around and change their meds. So you might still see some people on these medications. The advantage is they're less expensive than second generation, which are newer, but the disadvantage is that the incidence of extrapyramidal side effects is pretty high. Anticholinergic side effects, tardive dyskinesia, weight gain, sexual dysfunction, and endocrine disturbances. So many of these side effects are very disturbing, distressing to patients, and actually decrease their functional level. If you think about the person with tardive dyskinesia who is just twitching all over the place, facial grimacing constantly, can make it very, very difficult for them to live. So the disadvantages kind of in many cases outweigh the advantages. But again, we still might see these medications used, but just not as much as in the olden days. So Thorazine was actually the first antipsychotic to be discovered, and I believe it was probably around 1950 or so. So prior to that, patients just didn't even have anything to help them with their psychosis. So that's why they used to try lobotomies and insulin shock therapy and ECT and all kinds of things that weren't necessarily always helpful to patients. Just look at the extrapyramidal side effects just kind of really briefly. They're really well described on page 211 in Vecurolus. Acute dystonia is part of an extrapyramidal side effect. And boy, that is just really something that's really difficult. It's a sudden contraction of one of or several muscle groups, usually in the head and neck. So the neck can actually like twist to the side. It can block off the person's airway. So it really is something that we have to attend to immediately. It is very distressing for the patient, and usually an injection, a very quick injection of either Cogentin intramuscular or Benadryl will actually reverse that dystonic reaction really pretty quickly, maybe like 15-20 minutes. And of course we would want to stay with the patient because that's a very very distressing type of thing to happen to them. So along with that acute dystonia, they can also have an oculogyric crisis, which means their eyes roll back into their head and then they can't really see. So I remember a patient a long time ago who would get Thorazine, and he would get terrible dystonic reactions, and he would run up and down the hallway and screaming, dystonia, dystonia, and oculogyric crisis, and oh my goodness. So we really had to get those meds quick and give him the injection to reverse that. So again, part of extrapyramidal side effects could be that acute dystonia. Akathisia is something else that you might hear, and that's also part of extrapyramidal side effects. You know, there are several of those, and that's really motor restlessness, so a lot of pacing, and they just feel that they can't sit still, and that can be very distressing again to patients. They just feel completely restless and they can't even sit down and relax. So that is very distressing. And then something else called pseudo-Parkinsonism. So huge hint, when we give things like Artane, Cogentin, there's another medication, Symmetril, once in a while, when if somebody is prescribed an old antipsychotic, then they usually prescribe Cogentin or Artane maybe to be given a couple times a day, and you know, you're going to be looking up in the med book and it says, oh, for Parkinson's. Well, this person doesn't have Parkinson's disease. So I'm just telling you right now, the answer to that question is they have, as part of extrapyramidal side effects, is something called pseudo-Parkinsonism. So they have symptoms that look kind of like Parkinson's disease. So their arm swing is very reduced. They have tremors sometimes. They just masked face, slow moving, you know, just very slow movements. So that is all part of extrapyramidal side effects. Okay, anticholinergic side effects. You probably know what some of those are because you can have anticholinergic side effects to a lot of different types of medications that you're giving in other types of settings. So there's a nice purple table on page 215 and 216 that really describes a lot of these different types of side effects. So, of course, the anticholinergic side effects: dry mouth, urinary retention, constipation, blurred vision, dry eyes, all those types of things. So probably the most serious of all of those would be that urinary retention, because dry mouth you can kind of deal with. Constipation, we can kind of deal with that. Even the blurred vision, you might think, oh, that's serious, but actually it usually gets better as the person adjusts to their medication. But that urinary retention can be to the point where that person can't void at all, and they may need to be straight-cathed. So that is something we really have to look out for. Tardive dyskinesia is something that is a long-term effect, and sometimes students in the clinical setting have actually been the first ones to pick up on the fact that the patient is developing tardive dyskinesia. So the AIMS scale is something that I usually include in the clinical part of Blackboard for mental health, and you can take a look at that. So there's an actual assessment tool that we use sometimes to really look carefully for those symptoms. If we catch them quickly, it is very possible to reduce that. I do have a video of a man who has tardive dyskinesia. I'm not sure why he has tardive dyskinesia, if it was from antipsychotic medications or if it was from something else, but it doesn't really matter. If you watch the video, that's very accurate. That's what the symptoms are like. It is very distressing for the patient to have tardive dyskinesia. So if we can avoid that, because that's pretty much permanent, it can improve sometimes, but if we can be picking up on that and catching it early, it's very possible the physician can make medication adjustments and for that to improve. Okay. So next page, second generation antipsychotics. So these are serotonin receptors and dopamine. So they work on both serotonin and dopamine. So some examples: Latuda, Geodon, Clozaril. These medications treat both the positive and negative symptoms, which is great because the first generation only treated those positive symptoms. And the negative symptoms can really cause people a lot of distress and just inability to kind of carry out their day-to-day life. So it's really great that it can target both of those symptoms. Usually there's minimal to no EPS or tardive dyskinesia, which is great, but the biggest disadvantage is that they tend to cause significant weight gain and that risk of metabolic syndrome. And so these patients are developing type 2 diabetes. Clozaril especially can be known to have like 100-pound weight gain. That's a lot of weight. So, think about also, if you have significant weight gain like that, how motivated is that patient to stay on that medication? Yikes, not at all. If I was going to be prescribed something and told I was going to gain 100 pounds or I could gain 100 pounds, I'd be pretty hesitant to be on that medication. But it doesn't happen again to everyone, but it's certainly something that can happen. Just a side word about Clozaril. It's kind of treated almost as a class in a class of its own, because there is something called the Clozaril National Registry where they keep track of side effects, because there can be some very serious side effects to Clozaril. So agranulocytosis is one of the most serious side effects. So people have to be titrated on the Clozaril. Usually there's a schedule to slowly increase their dosage, all the while monitoring their lab values to make sure they don't develop agranulocytosis. And the other really serious side effect is actually orthostatic hypotension, to the point where people would be falling and getting hurt. So the other part of Clozaril, which is different from the other antipsychotics, is that if you ever have a patient with Clozaril, and I have had several students take care of patients that are on this medication, you are usually doing what we call Clozaril vital signs. So the vital signs, a full set of vital signs needs to be taken an hour before you give the Clozaril and then an hour after they take the Clozaril. And in the beginning, it's with every single dose. And at the end, if people are really adjusting very well, they're not having any difficulties, then maybe they're only doing it once a day. And it's possible that if somebody's been stable on Clozaril for a number of years, we may not even be doing the orthostatic vital signs any longer. But they would always be checking lab values and making sure they're not developing the agranulocytosis. So just a little side note about Clozaril, which is just a little bit different. We don't do those same types of interventions for the other medications. Third generation antipsychotics, it's really a subset of the second generation, so they're not all that different. So Abilify, Rexulti, Vraylar are some medications in that class. They're dopamine system stabilizers. They may improve positive and negative symptoms again, and some cognitive functioning, and again, little risk of EPS or tardive dyskinesia. Sometimes we are seeing Abilify being used actually more and more frequently as an adjunct treatment for depression, because there is something about this medication that actually helps the antidepressants to work a little better. So if somebody is on an antidepressant and they're not really doing very well, they're not, their symptoms aren't going away, they may add Abilify, and that can sometimes be the thing that helps their antidepressant to just work a little bit better for them. So potentially dangerous responses to antipsychotics. So anticholinergic toxicity, neuroleptic malignant syndrome, agranulocytosis, prolongation of the QT interval, and liver impairment. So these are things that we as nurses really have to be very careful about assessing for signs and symptoms. These dangerous side effects are discussed on page 216 and 217 in Vaccarolus. So anticholinergic toxicity is a potentially life-threatening medical emergency. And what's interesting about this is that, well, certainly if you are on multiple anticholinergic meds, people are at greater risk, and certainly if they're older adults. But what's interesting is that sometimes a symptom of that could be hallucinations. And so you might think that it's just their illness is getting worse. But if somebody has just really, there's no explanation for their worsening of psychosis, then we should be thinking that it's possibly anticholinergic toxicity. Neuroleptic malignant syndrome is very, very rare, actually. Only occurs in about 0.2 to 1% of patients who have taken first-generation antipsychotics. So it's very, very rare. And yes, a lot of medications will say, watch out for neuroleptic malignant syndrome. But honestly, I've only seen it probably twice in 38 years. Not really all that common, but certainly it is very serious, and that person will need to be treated in the intensive care unit. So it truly is a medical emergency. So what we're looking for is reduced consciousness and responsiveness, so decreased mental status, increased muscle tone, basically generalized like muscle rigidity to the point of being like lead pipe rigidity. So we're talking extreme muscle rigidity and autonomic dysfunction. So it's not, very likely, but it is life-threatening. It's a medical emergency. It is fatal in up to 10% of cases. And usually it happens earlier in therapy, but it can occur after even 20 years into treatment. So again, early detection by the nurse is absolutely imperative. So if you work in a mental health setting, or if you work in any setting and patients are on these medications, you really have to be very aware of the side effects and make sure that we're picking up on things very quickly. So we would not give that medication, call the doctor, manage their fluid balance, reduce their temperature, and monitoring for other types of complications, muscle breakdown. So it's really quite serious. Agranulocytosis, again, that's mostly associated with Clozaril, but it can happen with some of the other antipsychotics as well. Neutropenia can develop and can be fatal. So again, that's part of us keeping an eye on lab values, alerting the doctor so that they can take appropriate action. So some signs and symptoms that we're looking for would be fever, chills, sore throat, or increased susceptibility to an infection. prolongation of the QT interval can actually contribute to sudden death. So again, we have to be very careful. Some of the second generation medications like Seroquel, Risperidone, and Geodon can prolong the QT interval, so we have to be really careful there. And first generations, Thorazine, Haldol, and Mellaril also can be implicated in this cardiac emergency. So we really, again, as nurses, have to be very aware of making sure that appropriate tests are ordered for patients. And certainly we is always within our role to question a physician if we feel like something needs to be looked at more carefully. Liver impairment can also occur during antipsychotic therapy, first generation and second generations especially. So we're looking at liver lab values. We're looking for yellow skin and eyes, abdominal pain, ascites, vomiting, swelling in lower extremities, dark urine, pale or tar-colored stools, easy bruising. So we're always looking for those types of signs and symptoms. Okay, so some advanced practice interventions when we're thinking about people that have schizophrenia. Again, group therapy, individual or group therapy, psychoeducation, medication prescription and monitoring, basic health assessment, cognitive remediation, so different types of cognitive therapies, and family therapy can also be very helpful. So for evaluation, as part of the nursing process, we're always going to reevaluate their progress regularly and adjust treatment when needed. So we're adjusting our nursing interventions. Even after symptoms improve outwardly, inside the patient is still recovering. Set small goals. Recovery can take a long time. It may take months. Of course, a patient's not always going to be in the hospital for months, so at least if we can try to get them set up with some good support systems and aftercare, that can be very helpful. Active ongoing communication and caring is essential. So quality improvement, again, that's part of QSIN, so we always need to be incorporating evidence-based treatments, creatively develop and incorporate treatment innovations, examine outcome data to improve patient care, adhere to updated standards of care and guidelines that incorporate the latest evidence-based practices. Audience response question: which assessment findings represent a negative symptom of schizophrenia? Apathy, delusion, motor tic, or hallucination? So I'm hoping that you figured out that it was apathy. So again, if you think the negative symptoms are the blah symptoms, having apathy, not really caring one way or another what happens or what you do, or even if you get out of bed for the day, that would be an example of a negative symptom. Okay, I think I'm going to end this recording and start again anew with Chapter 27, still part of Learning Plan 5.